This is a talk, in fact, for the IVF, World IVF Day, 25th. I thought, let's have it today. So talking about IVF and ICSI journey of Bharat, its achievements, evidence, and excellence. As far as infertility is concerned, just now Dr. Dipti had said that 10 to 15% of married couples suffer from infertility. And it is very sad that 1% only seek treatment. Out of this 10 to 15%, 1% only seek treatment and its challenges which they face. The demand for assisted reproductive technology, including in vitro fertilization, has been on the rise. Now, let's know about the evolution of ART and IVF ICSI cycle, how it has evolved. In 1959, first came the discovery of sperm capacitation. It was M.C. Chang research on sperm capacitation provided crucial insights into fertilization, laying the foundation for assisted reproductive technology like IVF. Then came in 1969, first human oocyte was fertilized in vitro. Again, famous pair, Robert Edwards and Patrick Steptoe, successfully fertilized human egg outside the body, providing IVF as possible and revolutionizing infertility treatment. And we all know 25th of July 1978, the birth of Lucy Brown in UK, again given by Robert Edwards and Patrick Steptoe, offering hope to millions of couples worldwide as far as IVF is concerned. Then came 1978, 65 days after the birth of the Lucy Brown, was the birth of India's first IVF baby, Durga, and it was Dr. Subhash Mukherjee who pioneered India's first IVF success, though his contribution was recognized posthumously due to bureaucratic challenges. He was ridiculed by his colleague, laughed out, and they only created, along with them, the bureaucratic, harassing as far as this gentleman was concerned. So he finally committed suicide, and it is only after his death it was recognized. That also, many years had gone. It was Dr. T.C. Anand, who was the director of ICMR Institute in Parel. He was given honor that, you were one of the co-partners with Indra Huduja to have the first IVF baby. And he said, no, this was not done by us. The credit should go to this particular man. And he saw to it that this particular hassle was taken away by the government, and the government recognized it at that particular stage. So it was T.C. Anand who pushed it for that Subhash Mukherjee was pioneered as far as the IVF is concerned. 1980, I think I'm going to talk about this. You should listen it again on a webinar, which is by ISAR. I will be talking totally on all contributions as far as IVF in India is concerned. 1980, introduction of transvaginal oocyte retrieval came. Much later than the birth of the Lucy Brown, the adoption of ultrasound-guided egg retrieval made IVF less invasive, improving efficiency and the success rate significantly. In 92, we all know that the introduction of ICSI came by Professor Andre from Brussels, and ICSI enabled fertilization in a severe male infertility. And as we know that 50% of patients of infertility are male infertility, and this means directly injecting a sperm into the egg, enhancing IVF success in a very big way. Now, in 2000 came the advances of PGT, and the PGT allowed screening embryos for genetic disorders before implantation, improving pregnancy outcomes and reducing hereditary diseases and risk. Present and future AI and the gene editing in IVF. AI is enhancing embryo selection, while gene editing technologies like CRISPR are being explored for future applications despite ethical concerns. Infertility is on the rise in India due to lifestyle and clinical factors. Lifestyle changes, all of you know about it, that increasing marital age, rise in working women and a career prioritization by them, alcohol and tobacco consumption, obesity and sedentary lifestyle, no place for exercise, and all food from outside. And the clinical factors are in a very big way, we are affected by polycystic ovarian syndrome causing an ovulation. Endometrial tuberculosis is the key factor as far as Indian infertility problem is concerned. Sexually transmitted infections and poor ovarian reserve in South Asian women, including us. Our ovaries age 5 years earlier than our Western counterpart. And again, I repeat, it is the 1% seek medical treatment who are affected by infertility. Despite these rising infertility rates and awareness, only about 1% affected couples seek medical treatment, highlighting a significant gap in healthcare awareness and accessibility. Now coming to the Bharat's achievements and evidence and excellence. There is a rapid growth as far as IVF is concerned, and India is performing 2.5 to 3 lakhs IVF cycles. I will say this is ICMR data. COVID was a big setback. In 50% IVF houses, the shutters were on because it was a big gap and people found it very difficult to pay salary to their staffs. So I think 50% close, and that's why there was a big setback as far as the numbers of IVF cycles were concerned. But it is growing at the rate of 15 to 20%. This is cumulative annual growth rate given by the ICMR, reflecting massive accessibility strides. This is in spite of that 1% are seeking treatment. Global benchmarking is the live birth rate in the top of the Indian IVF clinics. It is 40 to 45%. Which was in 90s, it was around 10 to 15%. Now they match ASHRAE and ASHRAM benchmarks as far as Indian top IVF data are concerned. I'm not talking about those Indian doctors who claim that their rate is 90% or 100%. And if something like in the scale it was 200%, they will definitely claim. So that's why nobody believes Indian doctors when they come in terms of data, but this is the data which is provided by the ICMR. As for the technical adoption is concerned, universal ICSI adoption has been taken to the tune of 95% in the male infertility because it has been proven now that in male infertility, if ICSI is used, the results are great. Again, it is a Cochrane review. As for the cost and innovations are concerned, affordability, the average IVF cost is $2,000 to $3,500, which amounts to something like 2 to 3 lakhs of rupees. And it is supposed to be 60 to 70% lower than the US or the UK rates without compromising outcomes. The outcomes remains the same, so the cost is the 1/5. Now, as for the indigenous innovations are concerned, India developed cultures, media, equipments, and it has cut down the cost of whole infrastructures and otherwise to 40%. Again, ICMR validation is there to that. Whatever I'm talking about is facts. So I think you should take it with this thing. As for the medical tourism is concerned, 10% annual growth in fertility tourism due to quality and the cost. We have 1/5 the cost, and the quality as far as the results are concerned, they are matching the best of the centers in the world. As for the quality and the safety is concerned, the complication rate, OHSS is in India is less than 1.5% in accredited clinics compared to 3.3 to 5% global picture. And this is due to wide use of GnRH agonist triggers in ovulation induction cycles. Now, as for the single embryo transfer is concerned, again, this particular data has come from the ICMR that 50% people are doing a single embryo transfer. I have my reservations here. I find because more the number of the eggs are there, the upper ceiling is 3 by the government, that you can't put more than 3 eggs. But single egg transfer, whosoever I ask in Delhi, are you doing a single embryo blastocyst transfers, and most of the people say that for their results' sake they are not doing it. So I don't know from where this particular figure has come from the ICMR. Because outside it is mandatory that they will transfer single blastocyst because they do not want to have multiple pregnancy. Because who is going to take care of this particular lady, and it is not negotiable as far as a single embryo transfer is done, because they want to avoid multiple pregnancy at all cost. Now, as for the lab standards are concerned, accreditation by NABH has risen up to almost 68% of the IVF clinics, improving embryo viability. Evidence-based imperatives are PGS and PGD. Is a caution is there. It is routine. PGS for all ages is not recommended. It is said that if we could do it, it will probably double the cost, and that's why it is not recommended at all. And it is reserved only for a recurrent pregnancy loss and a patient who have advanced maternal age. Endometrial receptivity is concerned. ERA test showed no significant live birth rate, and that's why they have been packed up as far as this country is concerned in unselected patients. As for the luteal phase support is concerned, now there's a unanimity that micronized vaginal progesterone remains the gold standard for FET cycles. As for the guideline adoption is concerned, I think stimulation protocols, majority of us started using NTAC protocol, which dominates 75% of the cycle, and I will say that many experts are sitting here. It has gone up to almost 95% NTAC cycles. Reducing OHSs in a very big way, which was part and parcel of long agonist protocol, long protocol. Now, as for the freeze-all strategies are concerned, recommended for PCOS and high responders, it definitely cuts the OHSs risk by 5-fold. ASHRAE. As for the sperm selection is concerned, Picky and Hilo-Glow lack robust evidence for routine use, and that's why they are not being promoted. As for the equity and ethics are concerned, insurance coverage, only 12% of the Indian states include IVF in health insurance. A critical advocacy gap, and I think it should be that it should be covered by the insurance. As for the regulatory gaps are concerned, despite ART regulation of 2021, the surrogacy and the egg donation guidelines need stricter enforcement. Still, many people are there who are not founding the norms. As for the rural access is concerned, the Government of India figures are that tele-fertility consultation is expanded by 300% post-COVID. This is the AIMS study, but I do not find the reality across. What is the future forward? AI integration in embryo selection will be definitely come in a very big way. The trials of a Delhi IIT pilot study has been there with the AIMS, and they found that it will have 20% higher viability prediction by AI use. As for the mitochondrial health is concerned, there's a big market of antioxidant, which is industry driven. CoQ10 supplementation definitely improves the oocyte quality for people who are more than 35 years of old. It definitely has a place in male infertility as well. Cost versus outcome, no correlation found in the cost, cycle cost and the low birth weight. जो pump and show के बाद बहुत बड़े-बड़े डॉक्टर हैं और उनका बड़ा package है, does not mean that the results will be also the same. So there is no correlation found between the cycle cost and the live birth rate. They remains almost the same as far as the Indian multi-center studies are concerned. Our call to action is standardize your protocol. Adopt ICMR and ISAR guidelines for ovarian stimulation, for lab workflows, and for ET techniques. As far as auditing is concerned, they should be audited religiously, mandate clinic participation in Indian ART registry, combat quackery because 30% of IVF centers lack embryologists and demand strict licensing. Delhi and many other people in India, many infertility experts are there who have never had a basic training in infertility. And I, for one, definitely believe the people who are not trained in infertility do much more harm to patients than otherwise. Mental health integration includes mandatory counseling now, even for all infertility patients of yours, and that's why even in level 1 clinics also, they have made it mandatory that there should be mental health counseling should be there. Public IVF centers, I think we must learn from Kerala model and the Tamil Nadu model, where the government IVF centers give IVF cycles for 50,000 rupees. We must scale it nationally. As far as Delhi, 2 centers who are in the public sector medical colleges, again the cost is close to 1 lakh. As for the research investment is concerned, less than 5% clinic contribute to the RCT, and they should become partner with ICMR and for local evidence, because we must have to have a local evidence. No point following the West, because our profile and everything is very different. As for the genetic counseling is concerned, whenever you find there is any genetic abnormality, genetic counseling from the expert must be taken. It must be documented. We are not geneticists, so we are not in any positions to counsel these patients. It mandates PGT-M, PGT-SR for monogenic disorders, but again, the genetic counseling is must. As far as the male factor focus is concerned, 40 to 50% infertility is male related, and advocate andrology labs in all ART units. DNA fragmentation, which Dr. Aruna is going to talk about, is this particular test should be a part of the routine male workup. As far as the sustainability is concerned, can reduce single-use plastic in labs. Pilot studies have shown 70% waste reduction is possible. Now, coming to the final remarks of mine, Bharat IVF revolution proves excellence need no exorbitance. पैसे बढ़ाकर आप अपने rates को बढ़ा नहीं सकते. Success rates remains the same. Our cost comparable outcomes should become a global benchmark. But true leadership lies in unflinching adherence to evidence. Let's celebrate growth of IVF, yet we collectively demand governance, innovate but never ignore guidelines. For every life we create, we owe the rigor of science and training. Thank you very much.